change that background so bad.
You can't. All right. So now we're going to delve into a little bit more about the pediatric assessment. Some of it I'll kind of go through quickly if we've already kind of talked about it today, but we have some newcomers. So if you have questions, slow me down to ask. Okay? Yet again.
Yes. It says no. I think it's saying we should get off.
All right. So, patient assessment. Priorities are going to be pretty similar to adults. Priorities being like ABC or CABC, okay? Greater emphasis, again, is on airway and breathing because they're more likely to have airway and breathing compromise. Limit to essentials and then look before you touch, okay? So sick versus well, we're going to look at their overall appearance. We're going to assess their mental status, their effort of breathing, okay? Really important on these kiddos. What's their skin color like? The quality of their speech and or cry, depending on kind of their age. What's their interaction with the environment and the parents? How about their emotional state? Do they respond to y'all when you walk in the room? And then what's their tone and body position? These are all things that we need to look at. Remember, we talked earlier about that as I approach from here. So understanding pediatric developmental milestones is quite important. Is Cody still here?
Yes, that's here.
Okay. So interactions with the environment. What are we thinking? Is their age or their interaction or activity normal for their age? Okay. Are they playing? Are they moving around? Do they make eye contact? So when something happens around them, are they aware of their surroundings? Okay. This is equally important in adults as it is in pediatrics. Okay. Do they recognize their parents or do they respond to their parents? Are they just kind of like not really there, kind of checked out? Okay. And then are they attentive or non-attentive? Very important stuff. Again, this begins from across the room. What was the mechanism of injury? What are the surroundings? So if they started having respiratory distress and you see that there's a few Legos on the ground because Big Brother was playing with Legos, okay, that can be a pretty significant clue into that mechanism of injury as well. Yeah. What's your general impression? And my general impression is done, again, from across the room. Okay. What's my respiratory assessment? So what is their work of breathing or their respiratory effort? Okay. And then what's their perfusion? And for that, we're going to look at skin color when we're talking about from across the room, that approach to my evaluation. The pediatric assessment triangle is going to be a huge assessment tool for you. Okay. And this is kind of like your ABCs. And again, this is just as I'm approaching. This is how I develop my general impression, if you will. So this is the ABC of pediatric. This is going to be appearance, breathing, and then circulation to skin. Because I'm not even at my patient yet to start doing more of an assessment of the airway. Okay? So what's their appearance? Are they alert, verbal? Do they respond to verbal or painful stimulus? Or are they just completely unresponsive? What's their muscle tone like? Are they slumped over? What position are they in? This kind of stuff. What's their posture like? Are they in that tripod position where they can't breathe? Do they have that sniffing position where they're trying to open those airways and get every bit of oxygen they can get? Okay. How about their eye contact? Okay. That's a good one, right? You have to have cognitive thought processes. In order for you to have those kind of thought processes, you have to have a couple of things, and those things are oxygen and sugar. Okay? Breathing. I'm going to watch for sounds as I enter the room. Okay, that stridor, crowing, the grunting, any of the above. Retractions. Retractions. Where do retractions happen? Okay, so we have intercostal retractions that happen around the ribs. We have subclavicular retractions that happens like around the clavicles. They can have under the rib cage retractions. You watch for that seesaw or that belly breathing. Are they really pulling from their belly? Some of the other things I'm going to look at, nasal flaring from across the room. Like, remember, kids are obligate nose breathers. So if they're really flaring those nares to try to get a big breath, they're probably in some respiratory issues. Position, again, are they in that kind of tripod position? Are they able to sit up? Are they head bobbing so much that they can't even hold or maintain their position? And then you want to kind of look at the rate. Now remember that their rate's going to be fast anyway, okay? So again, from across the room, I just want to kind of go, how fast are we talking? I mean, are we talking 1 a second? I can kind of see that from here, okay? Circulation to skin, we're going to look at color and moisture if you can see it from across the room, okay? Some of it's going to depend on time of year and, you know, clothing and how they're dressed, okay? Okay, note this. Respiratory distress is going to have a normal appearance. They're going to have an abnormal or increased work of breathing, and their skin is going to be normal as well. Okay? There are 3 phases of every respiratory call or respiratory illness or emergency. They are distress. You guys know the next one? Respiratory distress is the first one. Respiratory failure, and then respiratory arrest in pediatrics. Okay? So respiratory failure is an abnormal appearance. So this is already decompensating, okay, if you will. Their breathing is going to be either increased or decreased. Remember, everybody passes through normal to die. Okay? So if they've been breathing really fast and you get there and now they're slowing down, that is an ominous sign. That means they're about to stop breathing. Okay? And then circulation to skin in this phase could still be normal or abnormal. All right? And that's your respiratory failure. Shock is going to be they have an abnormal appearance, but their breathing will likely be normal. It may be slightly increased, but they're not going to have that accessory muscle use, that work of breathing. Okay? So they may have just an increased rate. And then their circulation to skin is going to be abnormal. Okay? Y'all understand why that is? What do we start doing when we start going into shock? We start shunting. That's why you get this circulation to skin abnormality. You start shunting, so they're going to become pale or, you know, remember we're pulling away from the skin. They may be mottled because of the same thing. Remember those kiddos, okay? Take into consideration your environment as well.
So do you do the further test on the skin curve?
Mm-hmm. You have to do it centrally, and that's still not a sign that I use very often because there are more effective ways. Okay. All right. CNS dysfunction or metabolic abnormality. So what would be a CNS dysfunction or metabolic abnormality? I'll wait.
Seizure?
Seizure. Could be trauma. So what kind of trauma is going to cause this? Head trauma. Diabetes. Hypoglycemia. All right. Intoxications or ingestions. It happens all the time for pediatric patients. All right. So CNS dysfunction. This is going to be, they're going to have a normal, abnormal appearance, but they're going to be normally breathing and have normal circulation to the skin. Okay. What about this kid? Sick or not sick?
Sick.
Why? I want you to tell me what particularly about him that you can look at. Man, one thing.
He's breathing through his mouth.
Okay, so she's going to think this is a mouth breather,
I thought the same thing.
mouth breathing issue. What else? Say what?
Kind of ears are kind of funny.
His general appearance just looks,
His eyes are glazed. What else do you notice about his eyes, you guys?
they're kind of slanted. Lazy.
One of the lips kind of close to
Does he seem to be engaged with his environment?
No.
That's what we're talking about. That's that, you know, what are their eyes? Are they engaged? Are they looking? Are they following? Or are they concentrating so hard on breathing? What about this? It very well could be subclavicular retraction. It's kind of hard to see in this picture because you don't know. Maybe he's just a kind of a thin kid in general. Okay? That's definitely some of the things I'm going to look at. What else do you note about his position?
He's sitting up.
What's that called? Sniffing position. Why do they do that? Open those airways.
He does kind of look a little pale, too.
Okay.
That's just normal.
Look at his mouth, his lips. His lips are still pretty pink to me. I wouldn't probably be thinking he's pale. But his eyes are definitely glazed over. He's not really engaged or following. He may have these subclavicular retractions. His mouth is open. Okay. So position. Did we cover everything? ABCs. Okay. How about this one?
I would say yes, but I'm more curious what that thing is right there.
Well, we're going to talk about that thing.
Okay.
This baby is very sick.
Okay.
This baby is in respiratory failure. I will almost guarantee you. What did I see immediately on this picture that made me think like that? Brian, can you think of something?
We got like you said, the chest is kind of like pegged down a little bit.
That is retractions. This baby's retracting here. The baby's retracting here. He's nasal flaring. He's struggling. This baby's pale. Look at the color of his lips compared to the color of his skin. Where is his eyes? Not engaged. This baby is very sick. Struggling. This baby is probably, I bet you he's probably using the neck. But the problem is you can't see the neck. Like, think about our COPDers that we see. You'll see them using these accessory muscles. You can't see that on a fat little necked baby. Okay? How about this kid? I don't think his color looks very good. I'm with you.
Could that just be the picture though?
It could be.
His hair
Yeah,
kind of look yellow, too.
it could be.
Well, isn't that what I was thinking maybe that was there's some indication of
They might be.
Yeah.
So what else do you know? So his appearance. Let's talk appearance. Appearance. What are the things we're looking at?
He looks distressed.
Yeah, he doesn't look like he feels good.
But it's not like a.
Do you see? Okay, so let's back up. So his appearance, he looks jaundiced. Right? Can we agree to that? He looks a little yellow. Although the hand looks like it might be a little yellow too. What about breathing? What do you think about his breathing? Look at his posture, his position. Does he have anything that makes you think accessory muscle use? Is he retracting? Does he have nasal flaring? Is his mouth open?
No. He just probably
But he's so not engaged.
no, not good.
The person that's holding this is standing up here. Look, I mean, they have to be. He is not engaged. So what do you think is probably wrong with this kiddo? I'm thinking this is a CNS problem. It could be even metabolic. Maybe his liver isn't working. Okay, maybe it's not getting rid of some of these things. But do you see how I kind of got to the CNS stuff? His appearance is abnormal, but his breathing and circulation seem to be appropriate. You remember, go back to your slides, go back to your thinking. So this baby, shock. This baby is in shock. Respiratory distress. Or, well, respiratory failure. He might be respiratory failure or shock, either one. Okay? Y'all with me now? Excellent. How about this babe?
That baby has a disease.
Actually, it's not a disease. It's an illness.
Okay.
What do you think? Sick, not sick?
6.
It looks to be like he's got something on his mouth and helping him breathe.
Yeah, he's got an oxygen mask on. That's a pretty good indication they're sick. What else do you note, aside from the rash? Because that's the obvious. So appearance is...
Does he look fuller here?
Yeah, it was chest.
Yeah.
So is he retracting?
Yeah.
Okay, so he may be retracting a little bit. What do you note about his position, guys?
He's on his back.
I'm not talking about the position he's laying in. He's flaccid. This kid isn't moving. He's laying there. He's got no muscle tone. That's what we're looking at here. There is no muscle tone. Do you see that? You want me to tell you what's wrong with this kid?
Yes.
I bet you he's got meningitis.
Oh, yeah.
Yes, it can. Yep. Okay. So initial assessment is gonna help you characterize them, whether they're stable, are they in potential respiratory failure or shock, or are they definitely in respiratory failure or shock, and then are they in cardiopulmonary failure. Okay? That doesn't necessarily mean that they've arrested. We're talking cardiopulmonary failure. It's different terminology than what you're used to hearing. This is going to be almost irreversible shock, but they may still be functioning. They're just failing. Okay? So now we got to our hands-on assessment just now. We're going to assess breath sounds. Are they absent, present? What are some of our wheezing, stridorous type sounds? Okay? Again, we're going to listen to respiratory or lung sounds, especially the smaller the child, on this mid-axillary. So you're going to go this far lateral side of the chest, kind of up underneath the arms. This is where you want to listen. Why?
Least amount of resistance to the lungs.
Yeah, because they're the furthest points away from one another. So hopefully I'm going to hear this side versus that side. If I start listening up here, because they're so close, you're right. They're so close in distance and they're hyperresonant. This is really the only place you're going to be able to differentiate, maybe. Okay? And then assess the circulation. So brachial femoral pulse. Okay? What's their skin color? Don't forget skin temperature. Okay? Are they cool and clammy or not? Are they dry? Are their eyes sunken? What are their mucous membranes like? If they've got snot that's running, are they crying when they make tears? Are they making tears when they're crying? Excuse me. Okay? And then capillary refill. Capillary refill is a good assessment on pediatric patients as long as you're in an okay environment. Meaning, if it's Christmas Eve and they're involved in an accident coming home from grandma's house and it's 3 a.m. and they've been out laying in this ditch for a while, your capillary refill is probably not going to be a very good tool for you because chances are they're probably going to be pretty cold. Okay? And then we want to try to get a blood pressure if they're over 3. But again, we can still kind of assess perfusion with these other things in addition to the blood pressure. If you wait for a blood pressure to tell you that the kid is in trouble, it is too late. Okay? So, pulse rates for a newborn, 100 to 180. Infants, 100 to 160. See, right here at this toddler, ranges from 80 to 110. Okay, so their normal is still typically higher than ours. Okay? Preschooler can still be 70 to 110, but you see it's kind of starting to come down a little bit, kind of more like us. Okay? So you see that progression, 65 to 110 for school age. And then in early adolescence, and I don't know what they classify as early adolescence, because remember, adolescence is anything from 12 to 18. Now we're going to be talking 60 to 90. Okay? So right with us, essentially. Respiratory rates for a newborn is 30 to 60. Wow, that's pretty fast, okay? And that rate's going to continue throughout the first month of birth, okay? Toddlers are about 24 to 40. Now remember, these are normal ranges. So if you get a toddler that's breathing, 38 times a minute,
You're all right.
that's still within normal limits, okay? Now I'm going to look at what's their work of breathing like? What is their accessory muscle use? Are they nasal flaring? I'm going to look for some of those associated symptoms. Okay? Preschooler, 22 to 34. That's still significantly higher than what we breathe. What's our normal rate of breathing for an adult?
12 to 20.
Essentially 12 to 20. Some of it's going to vary based on what you read. Some of them will say like 10. Yeah. Okay? Now look, school age, they're still at 18 to 30. So 30 we would still consider to be tachypnic for an adult. Okay? So you got to remember that. And then in early adolescence, 12 to 16 is very normal for them. Okay? All right, so blood pressures. 0 to 3 months, systolic pressure should be about 70. Okay? And this is systolic pressure. 3 months to 2 years, it should be kind of around 90, which again, we would consider to be very hypotensive still. Okay? And then 2 to 10 years, you can kind of go 90 plus their age in years times 2. Okay? So if they're 2, then you're going to multiply it, and it's going to be 2 times
2,
is
4,
plus is
94.
okay. I'm just checking. Check and make sure you're with me. Mickey, are you with me?
Yeah.
Excellent. And the BP cuff size is extremely important. Now, we didn't talk about this a whole lot in adults, and it is important in adults too, right? If you use too small of a cuff, it's going to give you too high of a reading. If you use too large of a cuff, it's going to give you a low reading. Same thing with pediatrics. So it needs to be 2/3 the size of the arm, and we're talking width here, right? So it needs to take up 2/3 of this. Okay? So let's talk sick or not sick. 23-month-old, the appearance, the baby seated, alert, with a strong cry. Normal or abnormal?
That's normal.
Normal. Work of breathing, retractions and audible wheezing. Audible wheezing means I can hear it from here.
That's right.
I don't need a stethoscope to hear it. Normal or abnormal? Yeah, that's probably not very good. Circulation to skin, normal. So what do we think is going on? Respiratory distress. Who says respiratory distress? Okay. As you approach, the child yells, "Go away," and tries to hit and kick you, bite you. This kid's almost 2. Okay. Is this normal appearance?
Sure, why not?
Yes, because they have that fear of strangers.
Okay. And remember, they're going to get anxious. What are some of the things that make these guys anxious?
Mom and dad.
Well, mom and dad, yes.
Unknown.
Strangers, fear.
You counted up with a bunch of the stuff.
Yeah. We are scary people, folks. I'm just telling you. So be careful about kind of how you approach these kids, what you've got in your hands and what you're doing. Turn your radio down. Don't startle them. Right? Okay? So what are the expected behaviors of a toddler? This might be a bad kid. Maybe not. Okay? But yeah, is this kind of what you'd expect? Yeah, I would expect this from a kid, from a toddler. Okay? All right. 16 years old. Verbal, interactive, with normal body tone, muscle tone is what we're talking about. Normal work of breathing, circulation to skin is normal. Anybody wondering why we're here?
Yeah, it's not that he's alert.
No.
Right.
Verbal, interactive with normal tone. He's interactive or she.
That's normal.
Abdominal pain. You can have abdominal pain in all this. All right? Remember, they're 16, so they're going to have some of the same issues that you and I have. Okay? Is this young man's appearance normal?
Yes.
Okay, what are the special challenges you're going to face in assessing some adolescents?
Making them a part of their care.
Making them a part of their care.
Trust.
Trust.
Maybe modesty with them.
Yeah, you could have some modesty. Yeah, don't talk down to them. You got to be respectful. Secrets. We are a position of authority, right? To them, that's how they view us. They will have secrets. All right? My 12-year-old's got secrets, she thinks. Okay? Doesn't get any better when they become 16 or 17, 15, 13, whatever. Okay? 2-week-old. Eyes are open, moves arms and legs, and has a strong cry. Good or
That's normal.
normal or abnormal? Normal. Breathing. Abdomen rises and falls with each breath.
Normal.
Normal, right? Because otherwise you get that seesaw breathing. That's abnormal. Okay? Circulation to skin. The face and trunk is normal. The hands and feet are blue.
That's probably not good, but are they cold? Are they wrapped? Are they, I mean, these are all these questions.
I think these are appropriate questions. This is normal or abnormal?
Abnormal.
Abnormal. Typically it's abnormal. But remember, they are extremely susceptible to temperature. What about the baby's work of breathing?
It's normal.
At that age, they're usually better breathers because they have that.
Okay, but it's going up at the same time, right, instead of this seesaw breathing, okay? And we already kind of talked about the skin sign. Anybody concerned about the signs of the skin? I think it's something I need to be aware of. I think I need to kind of go, well, what's the temperature? And again, I'm going to know a little bit more as I'm approaching. And Ashley kind of talked about it. Are they wrapped up? Is it warm enough? You know what I mean? If it's 80 degrees in the summertime and they're outside and they're wearing, appropriate summertime clothes, am I worried? Absolutely. Absolutely.
But if it's refrigerator cold in their house.
Right. Then it's a 2-week-old, sure.
And they're in a onesie.
Sure. All right. Any questions on any of that, guys? Helpful or no?
Yeah.